Diabetes in pregnancy management from preconception to the postnatal period. This is the diabetes NICE guidelines. And diabetes in pregnancy is associated with the risk to the woman and to the developing fetus, highlighted valipartum. Miscarriage, preeclampsia, and preterm labor are more common in women with pre-existing diabetes. In addition, diabetic retinopathy can worsen rapidly during pregnancy. Stillbirth, congenital malformations, macrosomia, birth injury, perinatal mortality, and postnatal adaptation problems such as hypoglycemia are common in babies born to women with pre-existing diabetes. These are the complications: miscarriage, preeclampsia, preterm labor. More common in women with pre-existing diabetes, and diabetic retinopathy, if present already, it can worsen during pregnancy. Stillbirth, congenital malformations, macrosomia, birth injury, perinatal mortality, postnatal adaptation problems are common in babies born to women with pre-existing diabetes. So, preconception, planning and care. Advise women with diabetes who are planning to become pregnant to aim for the same capillary plasma glucose targets ranges is recommended for all people with type 1 diabetes. A fasting plasma glucose level of 5 to 7 millimole per liter on waking, and a plasma glucose level of 4 to 7 millimole per liter before meals at other times of the day. These are the levels, and these are very important. These are different from gestational diabetes levels. So these levels are very important to remember. Fasting plasma glucose level of 5 to 7 millimole per liter, and a plasma glucose level of 4 to 7 millimole per liter before meals at other times of the day. Gestational diabetes. Diagnosed gestational diabetes is the woman has either a fasting plasma glucose level of 5 to 6 millimole per liter or above, and a 2-hour plasma glucose level of 7.8 millimole per liter or above. So it's fasting, it's 5.6, and the 2-hour plasma glucose 7.8 millimole per liter. While preconception, if patient came for preconception planning, fasting plasma glucose should be 5 to 7 millimole per liter waking, and a plasma glucose level of 4 to 7 millimole per liter before meals at other times of the day. Now, antenatal care for women with diabetes. Advise pregnant women with any form of diabetes to maintain their capillary plasma glucose below the following target levels if these are achievable without causing problematic hypoglycemia. Fasting 5.3 millimole per liter, and 1 hour 7.8 millimole per liter, and 2 hour after meal 6.4 millimole per liter. These are very important to remember. Any forms of diabetes, gestational, type 1 or type 2. Fasting should be 5.3 millimole per liter, 1 hour 7.8, and 2 hour is 6.4 millimole per liter. Take urgently for ketonemia. Just urgently for ketonemia for pregnant women with any form of diabetes. Patients with hypoglycemia is unwell to exclude the diabetic ketoacidosis. Antenatal appointments provide specifically provide care specifically for women with diabetes, in addition to care provided routinely for the healthy pregnant woman. Now this is the timetable for antenatal appointments. Appointment care for women with diabetes during pregnancy. Booking appointment. Join diabetes and antenatal care ideally by 10th week. Discuss information, education and advice about how diabetes will affect the pregnancy If the woman has been attending for preconception care and advice, continue to provide information, education, and advice in relation to achieving optimal blood glucose control, including dietary advice. If the woman has not attended the preconception care advice, give information, education, advice for the first time, take a clinical history to establish the extent of diabetes, related complications including the neuropathy and vascular disease, and review medicines for diabetes and its complications. Offer retinal assessment for a woman with pre-existing diabetes unless the woman has been assessed in the last 3 months. Offer renal assessment for a woman with pre-existing diabetes if it has not been performed in the last 3 months. Measure HbA1c levels for women with pre-existing diabetes. Antenatal clinic every 1 to 2 weeks for pregnancy for all women with diabetes. Measure HbA1c levels for women with pre-existing diabetes to determine the risk level of risk for the pregnancy. And offer self-monitoring of blood glucose or send 5 gram to our OGTT as soon as possible for women with history of gestational diabetes who book in the first trimester. Okay, confirm viability of pregnancy and gestational age at 7 to 9 weeks. In 16 weeks, offer retinal assessment at 16 to 20 weeks to women with pre-existing diabetes. If diabetic retinopathy was present at their first antenatal clinic visit. Offer self-monitoring of blood glucose or send 5 gram to our OGTT as soon as possible for women with a history of gestational diabetes who book in the second trimester. 20 weeks. Offer an ultrasound scan for detecting fetal structural abnormalities, including examination of the fetal heart, 4 chambers, outflow tracts, and 3 vessels. 28 weeks, offer ultrasound monitoring of fetal growth and amniotic fluid volume. Offer retinal assessment to all women with pre-existing diabetes. Women diagnosed with gestational diabetes as a result of routine antenatal testing within 4 to 28 weeks into the care pathway. At 32 weeks, offer ultrasound monitoring for fetal growth and amniotic fluid volume. Often nulliparous women are routine investigations normally scheduled for 31 weeks in routine antenatal care. At 34 weeks, no additional or different care for women with diabetes. At 36 weeks of ultrasound monitoring for fetal growth and amniotic fluid volume, provide information and advice about time, mode, and management of birth, analgesia, anesthesia, changes to blood glucose lowering therapy during and after birth, care of the baby after birth, initiation of breastfeeding and effect of breastfeeding on blood glucose control, contraception and follow-up at 37 to 38 weeks. Offer induction of labor cesarean section if indicated to a woman with type 1 type 2 diabetes, otherwise wait spontaneous labor. 8 to 38 weeks, offer test of fetal well-being. And at 39 weeks, offer test of fetal well-being. Advise women with uncomplicated gestational diabetes to give birth no later than 40 plus 6 weeks. It's for gestational diabetes. If the patient has type 1 diabetes or diabetes prior to pregnancy, it's recommended to give birth at 38 weeks because as weeks passes, there is increased risk of stillbirth in diabetic pregnant women. When a woman with diabetes should also receive routine care according to the schedule appointment with the NICE guideline. Intrapartum care, advise pregnant women with type 1 or type 2 diabetes no other complications to have an elective birth by induction of labor or by elective C-section if indicated between 37 and 38 plus 6 weeks of pregnancy. It's type 1, type 2, no other complications, no other complications. Very important like macrosomia, polyhydramnios, and glucose is within normal range. Blood glucose is within normal range to have an elective birth by induction of labor or by elective C-section if indicated between 37 weeks and 38 plus 6 weeks of pregnancy. एडवाइस करना है वुमेन को विद gestation diabetes to give birth no later than 40 plus 6 weeks and offer elective birth by induction of labor or by cesarean section to women who have not given birth by this time. Postnatal care for women who were diagnosed gestational diabetes and whose blood glucose levels returned to normal after the birth, offer lifestyle advice, weight control, diet, exercise, offer a fasting plasma glucose at 6 to 13 weeks after the birth to exclude diabetes. For practical reasons, this might take place at 6 weeks postnatal checkup. If the fasting plasma glucose has not been performed by 13 weeks, offer a fasting plasma glucose test or HbA1c test if the fasting plasma glucose test is not possible after 13 weeks. Do not routinely offer a 75 gram 2-hour OGTT. Offer an annual HbA1c test to women who are diagnosed with gestational diabetes who have a negative postnatal test for diabetes. Now recommendations. Blood glucose and plasma glucose. These are the recommendations and diet, dietary supplements and body weight. Offer women with diabetes who are planning to become pregnant individualized dietary advice. Offer women with diabetes who are planning to become pregnant who have a BMI above 27 kg per meter square advice on how to lose weight in line with the NICE guideline. Advice women with diabetes who are planning to become pregnant to take folic acid 5 mg per day until 12 weeks of gestation to reduce the risk of having a baby with the neural tube defect. Monitoring blood glucose and ketones in the preconception period. Offer women with diabetes who are planning to become pregnant monthly measurement of the HbA1c level. Offer women with diabetes who are planning to become pregnant a meter for self-monitoring. And if a woman with diabetes who is planning to become pregnant needs intensification of blood glucose lowering therapy, advise her to increase the frequency of self-monitoring of blood glucose to include fasting levels and a mixture of pre and post meal levels. इसको दोबारा पढ़ लेते हैं. For women with diabetes who is planning to become pregnant needs intensification of blood glucose lowering therapy, advise her to increase the frequency of self-monitoring of blood glucose to include fasting levels and a mixture of pre-meal and a post-meal. ठीक है. ऑफर करना है वुमेन को टाइम डायबिटीज और प्लानिंग टू बिकम प्रेग्नेंट blood ketone testing strips and a meter, advise them to test for ketonemia if they become hyperglycemic or unwell. Target blood glucose HbA1c in the preconception period. Agree individualized targets for self-monitoring of blood glucose with women who have diabetes and are planning to become pregnant. Take into account the risk of hypoglycemia. Advise women with diabetes who are planning to become pregnant to aim for those capillary plasma glucose target ranges as recommended for all the people with type 1 diabetes. A fasting plasma glucose of 5 to 7 mol per liter on making and a fasting plasma glucose of 4 to 7 mol per liter before meals at other times of the day. Advise women with diabetes who are planning to become pregnant to aim to keep their HbA1c level below 48 millimole per liter, that is 6.5% HbA1c level. This is achievable without causing problematic hypoglycemia. Reassure women that any reduction in HbA1c level towards a target of 48 millimole per mole, 6.5% is likely to reduce the risk of congenital malformations in the baby. Strongly advise women with diabetes whose HbA1c level is above 86 mmol per mole 10% not to become pregnant because of the associated risk. Very important. All other blood oral glucose monitoring should be discontinued before pregnancy and insulin substituted. इसका पढ़ लेते हैं कि safety of medicines for diabetes before and during pregnancy. Women with diabetes may be advised to use metformin as an adjunct alternative to insulin in the preconception period and during pregnancy when the likely benefits from improved blood glucose control outweigh the potential for harm. All other oral blood glucose lowering agents should be discontinued before pregnancy and insulin substituted. Be aware that data from clinical trials and other sources do not suggest that the rapid-acting insulin analog Lispro adversely affect the pregnancy or the health of the fetus or newborn, so it's safe. बट स्टिल प्रेगनेंसी में सिर्फ जो है वो मेटफॉर्मिन अगर ये कंट्रोल हो रहा है इससे इट्स मोर देन इनफ मेटफॉर्मिन. और ये है कि यूज आइसोफेन इंसुलिन आल्सो नोन एज एनपीएच इंसुलिन as the first choice of long-acting insulin during pregnancy. Consider continuing treatment with long-acting insulin analog, insulin detrimer, or insulin glargine in women with diabetes who have established good blood glucose control before pregnancy. Safety of medications for complications for diabetes before and during pregnancy. Angiotensin converting enzyme inhibitors and angiotensin II receptor antagonists should be discontinued. Statins should be discontinued. Retinal assessment in the preconception period. Offer retinal assessment when diabetes seeking preconception care at the first appointment unless they have had annual retinal assessment in the last 6 months and then annually if no diabetic retinopathy is found. Carry out retinal assessment by the digital imaging with mydriasis using tropicamide. Advise women with diabetes who are planning to become pregnant to defer rapid optimization of blood glucose control until after retinal assessment and treatment has been completed. Renal assessment of the preconception period. Offer women with diabetes as renal assessment include a measure of albuminuria before discontinuing contraception. If serum creatinine is abnormal, 120 micromole per liter or more, the randomized creatinine ratio is greater than 30 mg per millimole, though estimated GFR less than 45 ml per minute. Referral to a nephrologist be considered before discontinuing contraception. Now, gestational diabetes risk assessment, testing and diagnosis. So that women can make informed decisions about risk assessment testing for gestational diabetes. Explain that in some women, gestational diabetes will respond to changes in diet and exercise. The majority of women will need oral blood glucose lowering agents or insulin therapy if changes in diet and exercise do not control gestational diabetes effectively. If gestational diabetes is not detected and controlled, there is a small increased risk of serious adverse birth complications such as shoulder dystocia. A diagnosis of gestational diabetes will lead to increased monitoring, will lead to increased interventions during both pregnancy and labor. Assess risk of gestational diabetes using risk factors in a healthy population. At the booking appointment, determine the following risk factors for gestational diabetes: BMI above 30 kg per meter square, previous macrosomic baby weighing 4.5 kg or above, previous gestational diabetes, family history of diabetes, first degree relative with diabetes, minority ethnic family origin with high prevalence of diabetes. Offer women with any of these risk factors testing for gestational diabetes. Do not use fasting plasma glucose, random blood glucose, HbA1c glucose challenge test, urinalysis for glucose assessment for developing gestational diabetes. Glycosuria detected by routine antenatal testing. Be aware that glycosuria of 2 plus or above on one occasion or of 1 plus or above on 2 or more occasions detected by reagent strip testing during routine antenatal care may indicate and diagnose gestational diabetes. If this is observed, consider further testing to exclude gestational diabetes. Testing use a 2-hour 75 gram OGTT test for gestational diabetes in women with risk factors. For women who have gestational diabetes in a previous pregnancy, early self-monitoring of blood glucose or a 75 gram 2-hour OGTT as soon as possible after booking, whether in the first or second trimester. A further 75 gram 2-hour OGTT at 24 to 28 weeks if the result for the first OGTT are normal. For women with any of the risk factors for gestational diabetes mellitus at 2 hours and 5 gram 2 hour OGTT at 24 to 28 weeks. Diagnosed gestational diabetes if the woman has either a fasting plasma glucose of 5.6 and 0.8, and offer women with the diagnosis of gestational diabetes a review of the Joint Diabetes Antenatal Clinic within 1 week. Interventions. Explain to women with gestational diabetes about the implications about the short-term and long-term of the diagnosis for her and her baby, that a good plasma glucose control throughout pregnancy will reduce the risk of fetal macrosomia, trauma during birth for her and her baby, induction of labor and cesarean section, neonatal hypoglycemia, perinatal death. The treatment includes changes in diet and exercise and could involve medicines. Teach women with gestational diabetes about self-monitoring of blood glucose. Use the same Capillary plasma glucose level target levels for women with gestational diabetes as for women with pre-existing diabetes. Tailor blood glucose loading therapy to the blood glucose profile, personal preferences of the women with gestational diabetes. Advise women with gestational diabetes to eat a healthy diet during pregnancy. Emphasis that foods with a low glycemic index should replace those with a high glycemic index. Refer all women with gestational diabetes to a dietitian. Advise women with the gestational diabetes to take regular exercise, such as walking for 30 minutes after a meal to improve blood glucose control. Offer a trial of change in diet and exercise to women with gestational diabetes who have fasting plasma glucose level below 7 millimole per liter diagnosis. Offer metformin to women with gestational diabetes if blood glucose targets are not met using changes in diet and exercise within 1 to 2 weeks. Offer insulin instead of metformin to women with gestational diabetes if the metformin is contraindicated or unacceptable to the woman. Offer addition of insulin to the treatments of changes in diet, exercise, and metformin for women with gestational diabetes if blood glucose targets are not met. Offer immediate treatment with insulin with or without metformin, as well as changes in diet and exercise to women with gestational diabetes who have fasting plasma glucose level of 7.0 millimole per liter or above a diagnosis. Consider immediate treatment with insulin with or without metformin, as well as changes in diet and exercise for women with gestational diabetes who have a fasting plasma glucose level between 6 to 6.9 millimole per liter if there are complications such as macrosomia or hydramnios. Polyhydramnios. Consider glibenclamide for women with gestational diabetes in whom blood glucose targets are not achieved with metformin but who decline insulin therapy or cannot tolerate metformin. Antenatal care for women with diabetes. Advise pregnant women with type 1 diabetes to test their fasting pre-meal, 1 hour post-meal, and bedtime blood glucose level during pregnancy. Advise pregnant women with type 2 diabetes for gestational diabetes who are on a multiple daily insulin injection regime to test their fasting pre-meal, 1 hour post-meal and bedtime blood glucose levels during pregnancy. Monitoring HbA1c, measure HbA1c levels in all pregnant women with pre-existing diabetes and the booking of appointment to determine the level of risk to the pregnancy. Consider measuring HbA1c levels in the second trimester and third trimester of pregnancy for women with pre-existing diabetes to assess the level of risk for the pregnancy. Do not use HbA1c levels routinely to assess women's blood glucose control in the second and third trimester of pregnancy. Managing diabetes during pregnancy, insulin treatment and risk of hypoglycemia. Be aware that rapid-acting insulin analogs aspart and Lispro have advantages over soluble human insulin during pregnancy. Consider the use. Advise women with insulin-treated diabetes of the risk of hypoglycemia and impaired awareness of hypoglycemia in pregnancy, particularly in the first trimester. Advise pregnant women with insulin-treated diabetes to always have available a fast-acting form of glucose, for example, dextrose tablets or glucose-containing drinks. Provide glucagon to pregnant women with type 1 diabetes for use if needed. Instruct the woman and a partner or the family members for its use. Continuous glucose monitoring. Do not offer continuous glucose monitoring routinely to pregnant women with diabetes. Consider continuous glucose monitoring for pregnant women in therapy who have problematic severe hypoglycemia, with or without impaired awareness of hypoglycemia, or who have unstable blood glucose levels to minimize variability or to gain information about variability in blood glucose levels. Ketone testing and ketoacidosis. Offer pregnant women with type 1 diabetes blood ketone testing strips and a meter and advise them to test for ketonemia to seek urgent medical advice if they become hypoglycemic or unwell. During pregnancy, admit immediately women who are suspected of having diabetic ketoacidosis for level 2 critical care, whether they can receive both medical and or obstetric care. Organization of antenatal care. Ensure that women with diabetes have contact with the Joint Diabetes Antenatal Clinic for assessment of blood glucose control every 1 to 2 weeks. Preterm labor in women with diabetes. Diabetes should not be considered as contraindication to antenatal steroids for fetal maturation or tocolysis. In women with insulin-treated diabetes who are receiving steroids for fetal maturation, give additional insulin according to an agreed protocol and monitor them closely. Do not use beta-mimetics medicines for tocolysis in women with diabetes. Time and mode of birth, intrapartum care. Advise pregnant women with type 1 diabetes no other complications to have an elective birth by induction of labor by elective C-section if indicated between 38 plus 6 weeks of pregnancy. Consider elective birth before 37 weeks for women with type 1 diabetes if they are metabolic or there are maternal fetal complications. Advise women with gestational diabetes to give birth no later than 40 plus 6 weeks and offer elective birth by induction of labor or by C-section to women who have not given birth by this time. Anesthesia. If GA is used for the birth in women with diabetes, monitor blood glucose every 30 minutes from induction of general anesthesia until after baby is born and the mother is fully conscious. Blood glucose control during labor and birth. Monitor capillary plasma glucose every hour during labor and birth in women with diabetes. Ensure it's maintained between 4 and 7 mmol per liter. IV dextrose and insulin infusion should be considered for women with type 1 diabetes from the onset of established labor. Use IV dextrose and insulin infusion during labor and birth for women with diabetes whose capillary plasma glucose is not maintained between 4 and 7 mmol per liter. Neonatal care carry out blood glucose testing routinely in babies of women with diabetes at 2 to 4 hours after birth. Carry out blood tests for polycythemia, hyperbilirubinemia, hypocalcemia, hypomagnesemia for babies with clinical signs. Women with diabetes should feed their babies as soon as possible after birth within 30 minutes and then at frequent intervals every 2 to 3 hours until feeding maintains pre-feed capillary plasma glucose level at a minimum of 2 millimole per liter. If capillary plasma glucose values are below 2.0 millimole per liter on 2 consecutive readings despite maximal support for feeding, if they are abnormal clinical signs, if the baby will not feed orally effectively, use additional measures such as tube feeding or IV dextrose. Only implement additional measures if one or more of these criteria are met. Postnatal care, blood glucose control, medicines and breastfeeding. Women with insulin-treated pre-existing diabetes should reduce their insulin immediately after birth and monitor their blood glucose levels carefully to establish the appropriate dose. Explain to women with insulin-treated pre-existing diabetes that they are at increased risk of hypoglycemia in the postnatal period, especially when breastfeeding. Advise them to have a meal or snack available before or during feeds. Women who have been diagnosed with gestational diabetes should discontinue blood glucose lowering therapy immediately after birth. Women with pre-existing type 2 diabetes or breastfeeding can resume or continue to take metformin, glimepiride immediately after birth, but should avoid other oral blood glucose lowering agents while breastfeeding. For women who are diagnosed with gestational diabetes and blood glucose level return to normal after birth, offer lifestyle advice which includes weight control, diet and exercise. Offer fasting plasma glucose at 6 to 13 weeks after the birth to exclude diabetes. For practical reasons, this might take 6 weeks postnatal checkup. For women having a fasting plasma glucose test as the postnatal test, advise women with a fasting plasma glucose level below 6.0 millimole per liter that they have a low probability of having diabetes at present. They should continue to follow the lifestyle advice, including the weight control, diet, exercise given after birth. They will need an annual test to check that their blood glucose levels are normal. They have a moderate risk of developing type 2 diabetes and offer them advice and guidance in line with the NICE guidelines. Advise women with a fasting plasma glucose level between 6.0 or 6.9 millimole per liter that they are at high risk of developing type 2 diabetes. Advise women with fasting plasma glucose level of 7.0 millimole per liter above, they are likely to have type 2 diabetes and offer them diagnostic tests to confirm diabetes. For women having a HbA1c test as the postnatal test, advise them with HbA1c level below 39 millimole per liter, 5.7% that they have a low probability of having diabetes at present. They should continue to follow the lifestyle advice, weight control, diet, exercise given after birth. They will need an annual test to check that their blood glucose levels are normal. They have a moderate risk of developing type 2 diabetes. Offer them advice and guidance. Advise women with an HbA1c level between 39 and 47 millimole per liter, that is 5.7% to 6.4%, that they are at high risk of developing type 2 diabetes. Advise women with HbA1c level of 48 millimole per liter, 6.5% above, that they have type 2 diabetes and refer them for further care. That was all about the diabetes.